an irrational, very extreme belief that something really bad is going to happen to my caregivers if I'm separated from them. Generalized anxiety disorder is everything in the world is the source of threat and fear. I'm worried that I slept in too long. I'm worried that I woke up too early. I'm worried that I didn't study enough. I did study, I studied too much. Generalized anxiety, the world seems like a pretty threatening place. And you say it's the Woody Allen syndrome and it's neurosis, but if you have generalized anxiety disorder, the world's a pretty tough place to live in. Very common anxiety disorders are phobias, specific fears. So, fear of heights, acrophobia. Fear of the number 13, fear of snakes. There's all sorts of phobias that are specific. You think, well, phobia's not that bad. If you are on the bridge and you have a bridge phobia, if a snake comes in and you really have a snake phobia, how severe is your fear and anxiety? It's at panic level. So a phobia isn't a laughing matter because if you're confronted with that stimulus that really gets you upset, panic level fear can take place. Then there's social phobias. This, as you might guess, occurs in older kids and teens. I'm not going to speak in front of class. I'm not going to ask anybody out. So it's a real fear of being what? Evaluated by others. And it kind of mimics Evan's progression later in his childhood of being embarrassed. But now you're so afraid of being embarrassed that you will not interact. Then we've got panic disorder. Panic disorder is defined as somebody with a history of panic attacks. And in about 80% of cases, what develops if you have panic disorder? Agoraphobia. You're going to develop literally a fear of fear. I will do anything to avoid having that panic attack that happened when I was out at Walgreens. So I'm not going to go out shopping anymore. I'll have home delivery only. So you selectively and progressively restrict your range so that you can keep that panic under control. There's another disorder called OCD, which seems to be in a pretty interesting separate group. It might be one of the few things in DSM that's really a disorder and not just sort of on the dimensions of fear and anxiety. Obsessive compulsive disorder. What's an obsession? Oh man, I didn't turn off the stove before I left for Psych 131 today. I think I did. No, I was making oatmeal. So that's an obsession. It's a worry you can't get out of your head. What's the compulsion? I got to block away and I drive back and make sure that stove is turned off. My hands are full of germs. I'm obsessed with dirt, uncleanliness. What's the compulsion that usually follows? Compulsive hand washing. What does the hand washing do? Temporarily relieves the anxiety until you think, maybe I didn't use enough soap. Maybe I didn't scour my hands. Maybe I didn't see any blood. Maybe I should use some rubbing alcohol. Because the temporary relief from the anxiety, from that obsession, usually doesn't last very long. So what happens? You do a compulsion even harder, and it makes you worry even harder, and so you get a cycle. That's obsessive compulsive disorder. And then there's post-traumatic stress disorder, PTSD. So this is 1, 2, 3, 4, 5, 6 categories. Don't memorize all the symptoms. It will drive you crazy. The symptoms overlap. There's not a perfect categorical system here, but we're going to think about the patterns. When do you see these things appear? Earlier in development, later, and how impairing they might be. We're going to talk about depression soon, not today. One theory of depression is, look, if I'm anxious, my negative emotions are high. I'm really scared. But I might, if I'm not thinking about it, I might have some good positive affect too. But depression is both having high negative thoughts and feelings, but I can't muster any positive emotion. So depression is a step up in this view from anxiety, and that you've got high negativity in your affect and low positivity. Anxiety alone, you might have positive affect or not, but it's really intensely high negative affect. So separation anxiety disorder is pretty common. When is not wanting mom and dad to go out with a babysitter a problem for mom and dad, and when is a disorder? Well, like anything else in the DSM, when it gets impairing, when the kid won't go to kindergarten or first grade. It's stressful. It's stressful for everybody, especially when you get into school refusal. So now you've got a family losing time from work because their first grader will have a tantrum and cry for 2 hours, and none of the other first graders can learn, and so the parents either have to stay from 9 to 10 and 10 to 11 o'clock, or if it gets so bad, we'll say, well, let's just do sort of pretend homeschooling. We're not going to send you to school. What happens when the parents say, well, I don't think we can send you to school. We're going to have to get a leave from our job and stay home with Billy all morning and afternoon. What does that do for Billy's fear and anxiety? What's Billy afraid of? Being away from parents and being in that school setting. So the parents take Billy in, and Billy's like, maybe I can make it today, and then the parents sort of walk down the hallway, and Billy hears the car ignition, and Billy freaks out. Billy's in a state of intense negative affect. And then the teacher calls the parent on the cell phone and says, get the heck back in, and what happens when Billy is now taken out of the classroom? Negative reinforcement, remember? There's an aversive state. Billy's totally freaked out, almost panicking, and now, what makes that go away? Billy's out of the classroom. What's reinforced? The parents for taking Billy out, and Billy's saying, I don't have to go to that school anymore. So whatever caused that intense separation anxiety and school phobia, we don't know exactly what caused it, but how is it maintained? By Billy's avoiding school. So what do you do if you're a clinician and you're treating school phobia? You make Billy stay at school. There's no two ways about it. There's nothing you can do at home. There's no lectures. There's no therapist at home who can say, now, Billy, tomorrow we're going to try this. You've got to get Billy not to escape the situation. This is the theory of the treatment of just about every anxiety disorder now. Whatever caused it, maybe some people are genetically wired to be negatively affective. Maybe there was a traumatic event. We can't control much of that. What we can control is you've got to stay in contact with what you're afraid of. And what usually happens when you stay in contact? After a while, Billy says, school ain't so bad, right? I've got friends here. I'm learning. But you've got to get Billy to overcome that initial anxiety to get to the place where he likes school. You've got to expose the individual to the feared stimulus. Anything else is probably not going to be very effective. So what about generalized anxiety disorder? We're going into a little detail on that slide a couple of slides ago. This is a hard one to treat. I know if Billy's afraid of school. I know if Sally's afraid of the bridge. But with generalized anxiety disorder, life freaks you out. And it's hard to be exposed to life. I mean, it is because we all are, but what's the specific thing you're trying to overcome? So what happens for people with generalized anxiety disorder? A lot of times they get medications, whether they go to a doctor or not. Alcohol temporarily makes you less anxious. Downers, anti-anxiety medicines, all of which are somewhat addictive, can temporarily help you feel less anxious. But what's the problem with the medication treatment of anxiety disorders? They're not teaching you to overcome what you're afraid of. Phobias. So there's many, many specific phobias because you can be afraid of lots of things out in the environment. And then social phobia now has a kind of newer name as of DSM-4, now DSM-5, social anxiety disorder. You're afraid of speaking up. You're afraid that you might sound stupid. You're afraid of being interviewed. You're afraid of asking somebody out or being seen in public. And it turns out that the real fear in many cases is of being evaluated. You're going to look like a jerk. You're going to look incompetent. So most people with phobias realize, I don't think I should really be afraid of flying in an airplane. It's a million times safer to fly to LA than to drive on Interstate 5 to LA. I really think once I start speaking, I'll do fine. You have insight, but you can't overcome the irrational fear by just insight alone. So in the olden days, in psychoanalytic treatments, you'd analyze the roots. Was it being toilet trained at the wrong time, or was it conflicts with your family? Now the treatments for phobias are exposure. No matter if you do it slow or fast, which we'll talk about a little bit later in the course, you've got to get exposed to the feared stimulus, and the theory is then you will extinguish the fear. So, just a little bit more on this now. Let's say you're really deathly afraid of the bridge. One kind of exposure treatment is called systematic desensitization. So you're sitting there with a psychologist, and the psychologist and you have a couple of sessions, and you have like 20 points. Number one is, I see a postcard of the Golden Gate Bridge. Barely makes me a little anxious. I get a little tingle. Number two, number three. Number 20 is, I'm dangling over the edge of the Golden Gate Bridge, and the sharks below are opening their mouths, right? Highest on the hierarchy. So the therapist says, okay, we're number one today. We're going to look at that postcard. How anxious are you? Well, just a little bit, maybe 3 on a 1 to 10 scale. Now the therapist teaches you to relax or does some cognitive work with you, and all of a sudden you say, well, okay, I guess that's not so bad to look at the postcard. Then the next session you go to number 2, number 3. And then finally, weeks later, you're out dangling over the Golden Gate Bridge, and the therapist is helping you relax, right? You're gradually counter-conditioning away the fear at each step. So it's slow and systematic. The other is, we're going after the Golden Gate Bridge on session 1. Flooding is a very fast behavioral therapy for anxiety disorders, where you don't have to go slow and systematic. Boom. We're going to expose you to your worst fear, and you'll overcome it. Now, what's an interesting aspect of treating a lot of kids' fears these days is virtual reality. There are some kids who are so terrified of heights that if they go to an elementary school that's on 2 floors, they can't ever make it to 4th grade because it's on the 2nd floor. So what's the therapist going to do? Walk the kid up the stairs each day? It won't happen. So now with virtual reality machines, you can go in and program it to have the kid think they're on an elevator walking up the stairs, and you relax the kid during the virtual reality. Very effective, very expensive, but again, what's the idea? Expose the person to the feared stimulus, and that anxiety will extinguish, because it's not as bad as you feared. Medicines can help phobias a little bit, but they don't teach you how to be exposed to the feared stimulus. So behavioral and cognitive therapies are really the treatment of choice. So agoraphobia. Now I'm afraid of being outside. I'm afraid of being, what's agoraphobia mean? Literally the fear of the marketplace. The agora was the market in ancient Greece. Fear of being at the mall, fear of being in the freeway, fear of being outside. Usually the trigger is what? You've had a panic attack. And now you're trying to systematically not get in a situation that would lead to that panic attack. If you've had a panic attack, you'll do anything to avoid it. It's pretty awful. Agoraphobia, as we were just talking about a few minutes ago, is literally a kind of fear of having a panic attack, and you now cut back your range so that you won't be in a situation of having one again. Now, how much agoraphobia is there? Well, we thought for a long time it was very low prevalence. Why? Because people would never show up at a therapist's office because they were afraid of leaving their home. If you do systematic surveys on the phone and ask people symptoms, it's more prevalent than we used to think, but it's so impairing and restricting that we were misled when we only went to clinics to find it. What do you do for agoraphobia? Well, here is a place where there are some medicines that really help decrease the frequency of panic attacks. But then systematically, you're going to need to get the person to face the potential reality of having a panic attack, and often this isn't done in the office. The therapist will drive alongside you on the freeway or accompany you down the street to the mall or a block or 2 away to the mall so that you've got somebody there to support you, and then gradually the therapist fades out. Obsessive-compulsive disorder. Another one we thought was really rare, but it's not as rare as you think. Most people with OCD are spending a lot of time inside, not at a therapist's office, doing what? Washing their hands or doing counting rituals or checking the stove. The compulsive behavior, what's the hope that it's doing? It's undoing the anxiety. It's undoing the obsession. If we had more time, we'd do more cases. There's a fairly famous case of a 12-year-old girl who started her OCD when she's 8 or 9. That's a very common age for kids to start OCD, late in their elementary years. Another common age to start is in your mid-teen years. And this girl really thought she was contaminated by germs, now would wake up at 3:45 a.m. each school day and wash her hands in rubbing alcohol for 3 hours. She'd lost the outer couple layers of her skin, she was having terrible skin diseases and infections, and had to go to the bathroom many times during each period in school to keep the washing. How did she feel about it? This is crazy. Why am I doing this? So most of the time in OCD, the person knows this is irrational, but why do they keep doing it? Because the obsessive fear is so strong, you'll do almost anything behaviorally, the compulsive behavior, to get rid of that fear. But it's a vicious cycle. Question? Well, there's a lot of types of obsessive. Turning off the stove, fearing that your mind's going out of control, so you have to count backwards from 1,000 many, many times. Hand washing is a very visible behavioral one, but there's a lot of others that are more cognitive that we don't get as much press. Yeah. What happened to this girl? So in this particular case, this is a good example of she got on SSRI medication, and she got a form of behavior therapy that I'll describe in a second, and the combination, OCD is a good example of medications help, cognitive behavior therapy helps. You put the two together, you really get improvement. So with OCD, what do? You probably have to turn down the thermostat. And it used to be anti-anxiety medicines, but they kind of just make you drowsy. The SSRIs, the antidepressants, are really good at reducing obsessional anxiety. But then what do you have to do for OCD to make it work? You have to get the person's hands dirty. So sometimes you have to, in very severe cases, do this in a hospital setting. You have the person rub their hands in dirt and mud. And what do you do then? Don't let them wash. They have to sit there with the dirty hands for an hour, freaking out. And what happens? The fear extinguishes. It wasn't so bad. It wasn't as bad as I thought to have the dirty hands. So if you dampen the thermostat with a medicine, the form of therapy is called ERP, exposure and response prevention. You expose the person to the dirt, and you prevent them from doing the hand washing. Often in a few days, the OCD goes away. But you have to keep up the treatment. Now, question a minute ago, hand washing is a good example here, because I can make my hands dirty, and the doctor doesn't let me wash them. But what if my obsession is the feeling I'm thinking impure thoughts? How do you expose a person to thinking impure thoughts? Easy to do with dirt on the hands, harder to do cognitively. So exposure and response prevention is a good but not a perfect treatment, because very cognitive obsessions are hard to mimic. One other thing about OCD, 80 to 85% of the time, the teenager says, I don't know why I'm doing this, but I can't help it. I'm really freaked out. What does that mean in terms of prognosis? That's really good. Because if you think it's irrational, you're probably a good responder to medicine and exposure and response prevention. About 15% of the time, the teenager says, well, everybody's like this, right? That's not a problem. I mean, if you don't keep your hands clean, everybody's going to get dirty. There's no insight. The person doesn't think it's a problem. That can be a sign of a more general thought disorder. It's not just an anxiety disorder if you're not pretty freaked out about it and if you think it's kind of normal. Now, PTSD is really important, and we're going to talk about it at the beginning of next time, so see you then.